thank you for the generous introduction, Shoaib. It gives me immense pleasure to welcome Shri G.S. Naveen Kumar, IAS, who is currently the Special Secretary, Health, Medical and Family Welfare for the Government of Andhra Pradesh. I also welcome all our students, alumni, faculty members, and anyone else connected to the IMV fraternity. So I also want to speak briefly about Shri G.S. Naveen Kumar. He is currently vested with the responsibility for handling computerization and hospital administration for the government of AP. And his experience spans 17 years, where he has worked with the government of Uttar Pradesh as Special Secretary IT, and also as in the Office of Commissioner Rural Development as Special Commissioner, and also as the Managing Director of the AP State Housing Corporation, among many other roles. So we formally welcome you, sir, to this student-run business colloquium. And the topic that I must mention for this keynote is creating a robust healthcare system in the post-COVID scenario, which Shri G.S. Naveen Kumarji will talk about. And Shoaib, do you want to speak something more about? Over to you.
Thank you, sir. Thank you, sir, from your warm words. Business cluster of IIM Visakhapatnam is honored to host a very instrumental person from Health, Medical and Family Welfare Department from Government of Andhra Pradesh, IAS G.S. Naveen Kumar. Sir is currently working as a Special Secretary in Health, Medical and Family Welfare Department for Government of Andhra Pradesh. Sir look after the computerization and hospital administration to serve the people of Andhra Pradesh through 7,500 sub-centers, 1,100 PHC, 190 CHC, 34 area hospitals, 8 district hospitals, and 11 teaching hospitals, along with a total bed strength of 33,000. Sir has more than 17 years of experience and worked with Ministry of Commerce and Industry for Government of India. Also as a Special Secretary for Government of Uttar Pradesh. By working in a very diverse portfolio of services in very integral position, Sir has emerged and evolved as a digital leader, helping India to create sustainable solutions. Sir has set up 15,000 Sachivalyams across Andhra Pradesh with a digital service across 3 crores and established a country's largest UPI payment based digital services from any state government. Recently, Sir is also completed 1 crore plantation in rural development. Without taking more time, I will now hand over to Naveen sir to enlighten the students of IIM Visakhapatnam with his phenomenal personal and professional journey so far. Over to you, sir.
I think you are very generous. I think you repeated most of the presentation. Thank you so much, and thank you, Professor Kalyan. So it's a pleasure to talk to students of IIM Vizag, because I think Shoaib also knows a couple of guys. In fact, my experience with IIM Vizag has been that when we started this, I had to tell you a background story why I like IIM Vizag. Also, the reason I interact with a lot of students from them. We had a lot of interns. I think you must have seen at least 20-25 students of IIM Vizag were my interns when we did this department of Gramavada Sachivalayam. So these guys, I remember very clearly, they were at home and they were keen to go to Sachivalayams. At that time, there was a lockdown. I think this was somewhere, I'm talking about March, April of 2020. So these guys, I think that I have a sentimental, or regards to IIM Vizag students. So it's a pleasure to address you today. The same topic, the way I interacted with IIM Vizag, the way we started with IIM Vizag, so same, I'm going to talk about the same topic today. When you see this entire crisis which went through our heads in the last 1-2 years, it's something which we never believed, or when someone told you that the crisis of this sort would come, we wouldn't have trusted that this would happen. But it did happen, and it certainly seems like a dream that our own lifestyle has changed beyond. I don't think our lifestyle will be the same. I think this generation of students, maybe the guys who joined somewhere in 2020 wouldn't even attended colleges. This is something unbelievable, right? So this is something which we have a new format of lifestyle which we are going to see. And you guys who are in this batch, I think probably the 2021 batch or 1920 batch, or the future batches would see a lot of difference. This is the biggest lesson you have to learn. Prepare yourself for any disruption. I think that's the most key point of our, how do we, respond to a disruption? The reason we responded to a disruption, that's one critical factor you must have seen when you analyze the countries which have gone through this disruption. We always talk about USA as one country that it is one thing which has been chasing merit all the time. One of the reasons USA is not even now, it's not responding to the way India has responded to this crisis, or any other country. I'm picking out a name. Any other country, is that we always had a robust public health system. So this is the guarantee. I think that when you see it in the wave 1, wave 2, it was only the public health responding systems responded. You guys must have seen a lot of experience personally. You must have gone to the private sector. There's always this belief that private sector would respond. But when you see it, public health systems has to be governmental for one reason. The rates have to be controlled. There are other regulatory issues, the quality of regulations, and the quality of services. That is also very, very critical, because any small compromise would mean that loss of life. So public health system is a very, very important sector, which is a growing sector. And I think one of the reasons the country has survived, or could respond. In fact, if you see most of the illnesses which we come across in our normal life, could have, if you had responded in the first to go, when it is in the preliminary stage of illness, it's a normal thing. I think everybody should know this one. If you respond to an illness at the early stage, it doesn't cost you much. It's more of a cost. If you put it in economic terms, I would call it a cost to the entire transaction. So if you respond to the illness at an early stage, you would actually control the cost of that transaction becoming a bigger one. I'm putting it in a very simplistic economic terms. So that is very, very critical. What we learned is that the entire COVID crisis, if you ask me, the guys who did, the people who did, responded properly without, taking it for granted, were the ones who could come out easily. And the people who had taken it for granted were the guys who were not coming out cleanly. So with these words, I think there are 6 critical areas which the entire system has to, when I'm talking about public health system, there are 6 critical areas. One is that we also have to increase the financing for what we call a healthy India. What we see is, when you see a GDP thing, we only contribute to 2 to 2.5. I think the number is around 2.5, 1.5. In fact, the number is 1.5 is the number which we are looking at. So we should increase this global spending on the health sector to at least to 2.5 to 3.5, where we would, when I'm talking about that early mechanism, you also have to clear, like what we have done in AP is, we have something called YSR health clinics. These are the smaller centers which are available at every village. So when you look at village level, I'll just see the scale of escalation, right? When you're looking at patients at village level, it's only 2 or 3. When it goes at a PSC level, it becomes 10, 20. And then when you go at a CSC level, it becomes hundreds. And then you go at a bigger hospital, it goes into thousands. And then you come at a medical college, it is more than thousands. So what is happening in this entire public health system is that if you can control, when I say that early detection, the same disease could have been responded in a better way at the last mile connectivity. It's just a viral, right? It's not that. And early detection also means that you take the vitals, you see that whether the vitals are correct, and you respond if that vitals are correct, and then you find out there is a need for escalating this case to refer the case to the next level. That's when we push it to the nut. So you see most of the health management systems, we do not take the scale of escalation. We just simply, the moment we think that, okay, there's a viral, so we immediately go to a medical college or we go to a district hospital. Already there is a load there, then we do not respond it. So it's again an economic cycle we look at. So which means when I'm talking about spending this 3.5% of GDP into this, we also have to create that local infrastructure and also the local knowledge. That's very, very critical. So what we are doing is, one of the things which we have done in AP in the last 1.5 years of this one, we have done several rounds of fever survey. We were proactively identifying people using our the entire Grama Ward Sachivalayam volunteers and the ANMs, And this would, I think that's what we were talking in the beginning of this conversation. We would respond to the fever survey in a very meticulous way so that there is no burden. If you see this entire COVID crisis, it's a logistic problem. The scaling of, you need to know who needs what care. There also, you must have read news of people squatting on oxygen beds, thinking that they would need it eventually. So they would occupy those things. So these are metrics which we were able to control it by doing fever surveys and responding to it. Second thing, it's a concurrent thing that we should also health system responding. Like the way I was talking about, these are both are connected. We need to increase the fund, and we also need to create an infrastructure where the money could be spent in a better way. When I talk about this one, there are three critical components. One is that physical infrastructure you need, and the skilled people. You need not need doctors and nurses responding, but you also need people who could identify this guy needs care. That is very, very important. And also the knowledge. The dissemination of knowledge is very, very critical. If you had seen, one of the challenges we faced during the first lockdown is none of our people were ready to understand what is this COVID, right? So, and suddenly you had a lockdown, and then we had to train people. And I was talking to the professor before this one. I was heading this organization called MEPMA. MEPMA is the one which takes care of shelter homes. Whoever doesn't have a home, they can stay in a shelter home, which is all over. Like Vizag has 3 shelter homes, and we also had to train our staff, 8,000 people at one go. So that's when we used a lot of online technologies to train people, assess them whether do they know it. WhatsApp is not the only way of pushing data. It's also that you need to know whether your staff is doing that. Metrics have to come. So we were able to strengthen the system. So when I talk about strengthening the system, it includes the soft skilling of the entire system and also the infra of the entire system. And also one more thing which happens in a public health crisis management is that you must have seen it, right? You need the members of the service to participate as a team. You need police to be a part of it. You need that municipality as a part of it. You need the health officials to be a part of it. Health officials eventually do it. So our fallback mechanism over the years had been the collector system, which we have across the country. So when we not respond to it, we make collector in charge because he is the guy or the person who can get everyone on board. And then so it is something like, it is more like an ad hoc system which we have always done it. And suddenly we'll set up a call center, we'll set up an emergency response system. In fact, you must have seen it that AP was also able to set up oxygen control rooms because there was a crisis across the state. Then we were able to set up oxygen control rooms across the state. So this is very, very important. We should, in the sense, there is this system which we have in this country called disaster management. So over a period of time, they do drills, they prepare you, and then they, when the disaster happens, for example, there was a flood. So I was in 2 flood districts in my service. So when you see a flood, you have a certain knowledge of how to handle a flood. It is a particular knowledge. So what NDMA has been doing, or SDMA, the State Disaster Management Agency or Authority, has been doing it over the past couple of years, maybe 5-6 years. They have been training these people, doing drills, educating them. How do you disseminate information? In fact, you must have also seen in that the major cyclone of Orissa, the first cyclone was a disaster. These are case studies I think students should read. And if you've seen the second one, Orissa was the only state which responded to that crisis in a better way with the minimal damage. So we always think that when you prepare a system, this is a very good, messaging or message to our own, inputs, that when you create a system, we can respond. I remember I'd always have this quote of Mr. Blair, the ex-prime minister of Britain. He always, I actually, paraphrase it all the time. He says, globalization is an eventuality, okay, but you can control its consequences. So I would put this word, I would change globalization. You can replace this word globalization and you can use it and put any other word. It's also, many things are an eventuality, but you also have the ability to control. Like cyclone is something which will definitely happen, but we can always prepare. Similarly, COVID is not the last epidemic which is going to hit us. It's not that we are through with it. That's exactly what we have. Sometime it happened also. So that I clearly remember that epidemics are going to happen. We should strengthen our system. not on ad hoc basis. We should, respond, prepare ourselves for the better. These are lessons which you learn from the last 2 years. And one of the things which we have always realized is that, in fact, you must have also realized when such crisis happened, I would not blame the doctors. I would call it healthcare management. I think I will put it that way. That's easy to, explain. They response. Everyone changes their response, right? Some people talk in a very different way, and some people talk, handle the same thing in a different way. There's also a need for unionization of this, the response to the healthcare response to the system or the people, or the way we respond. So which means that we need to skill our healthcare personnel on regular basis. It's not that only a bunch of doctors or bunch of hospitals are doing better and others are not doing better. Because when we have crisis of this order, it's a need that we need to skill them all at the same scale, that things are responded in a proper way. And the fifth, I think this is where I think there are last two areas which I think a lot of management students would participate in it. We need larger public-private partnership. I think this is where we are going to come in. You guys have to think of getting investments, setting up hospitals. That's one of the things which we are talking about. Hospitals need specialized management skills. If you had seen the way the corporate hospitals have grown in the past 15 years or 20 years, you must have also seen that there's a particular skill set which is required to run an hospital. It's not just we have a couple of doctors are there, we manage them. And this is a sign which is also a good sign. It's also a bad sign also, in the sense that it's corporatization of the healthcare that will happen. But it's also a very good sign that it is very, very important. Like one of the things which would happen is that we have a strong RHC network in this state. And all of these hospitals are, all of the, almost, I think I'm told 98 to 99% of the people of Andhra Pradesh are covered under orchestra, which means every healthcare is taken care of, which also gives you that scope for establishing better facilities within the state. So that is one thing which I'm talking of with respect to, Andhra Pradesh. And also there is a big potential across the country. It's simply, if you've seen it, I always had this experience from Lucknow. Lucknow is one city where we add only maybe 3 or 4 super specialties for a city of almost a crore of population, which is very, very unbelievable when you come to a southern state. The reason being, I think my own gut feeling is that I always say Adam Smith never works in Lucknow, because you always say there is demand for it. You'll always have that scope for creating an asset towards that direction, but which didn't happen there. So my feeling is that the lack of this particular hospital management skill. How do you bring a bunch of doctors to run an organization? Because they are all individualistic personalities, right? So that's very, very important. So I think Isaac, I think I did speak to Professor Kalyan before this talk. I think that's a very strong need. There's plenty of scopes for this one. I think you should probably, I think when you're looking at interning at an ITC or maybe interning at Marico or something, you should also try to intern at an hospital management school and understand how those things are taken care of. And the last one which we are doing big time, which is what I am reading right now, is the digital divide gap. So see, we also think the time is very, very crucial component. I call it doctor's time. So since the doctor has a minimal time and it's very expensive, we should also provide services around that, reducing that doctor's time, right? So that is one thing which we are looking at. So what we are trying to roll out in this, I think Shoaib was able to tell me how many centers we have in AP. And I also said the way the services escalate. We have a primary care, then we have a secondary care, and also we have a tertiary care. So all this would mean that there is also transaction time involved. I go to a doctor at the primary care, he refers me to a doctor in secondary care, and then the secondary care doctor refers me to a super specialty. There's a time taken. So to reduce this, one thing which we could do is that online registration where they can take appointments, and also the data, the diagnostic lab, the data. So that when you see the doctor, you don't have to carry all your records. So which is what we are trying. And you also would see this, one of the biggest thing which has happened in this entire vaccination drive is we have this portal called CoWIN. And CoWIN is first portal which would throw out a lot of APIs to the public. And one of the reasons these APIs were consumed in a bigger number, and then we were able to achieve the 100 crore, vaccinations. I think the last week we achieved 100 crore vaccinations, and that's itself is a big achievement. So this is also very, very important, which we'll see that there's also a tendency, and it's a good tendency with the government, that it's sharing its own API for the consumption of, for the general public with all the data security parameters. This is also scope for all of you. It's also a scope for you. You can also create services based on, if you understand how this data is provided to you, you can also create scope of services around it. You can also, create n number of, in fact, medical insurance services. You can also do risk analysis. You can also, predict what is the rate of because I think Professor Kalyan is doing this one. If I ask him what is the insurance rate per person, he will not be able to give you a rate, because he doesn't know in the next 5 years, 10 years, what is the major illness which is going to come. So I think this is going to revolutionize even the medical insurance sector in a big way. And also the number of beds we need. I think Shoaib mentioned we have 33,000 beds, but we also might need more beds. So these parameters would help you in understanding the future of healthcare we call it digital. It's not the digital. The digital is going to drive the data for the future of digital healthcare or healthcare in the country. So with this, I think this is the opening remarks I think I took, I don't know what is the time now. So I took some time. So I'll stop here. So if there is any questions, we'll take it and then we'll move forward. I think there are two.
So since I've been asked to moderate, if I may quickly kind of, if you'll indulge me, summarize kind of some ideas that you suggested,
Yeah.
and I'm tempted to place them within the context of economic theory, rather. You mentioned that not all diseases need to, not everyone needs to go through the entire, not everyone need to suffer just by implementing what I would like to call, or what rather the economics profession calls the 20/80 rule, where if you intervene in 20% of the cases, or at a time when it is most appropriate, which is rather small, 20%, you could avoid 80% expenditure later on. So you said, strengthening of primary health centers, and before you even get to the hospitals, and probably seeking preventive care will perhaps give timely intervention, given a timely intervention at those kind of, or investments in those areas, will prevent a lot of inefficient or rather wasteful spending later on. Was that the idea, sir, in what you suggested? In terms of utilizing the YSR health clinics, you said, or the network of local health workers, is one way to strengthen the public health system. Where is the spending impactful? And I'm tempted to say that if we apply the 20/80 rule, it might health cares and health delivery might not be as costly as we currently see. Public spending.
With this, I wanted to mention this one. See, there's a concept called essential drug list. So countries like, I think this has been successfully tested with the government of Tamil Nadu. They have a corporation from 1994. The drug list, you need only 200 to 250 to 260 only. And if you can, have those drugs, your entire healthcare system is taken care of. And I'm using the same formula. 90% of your healthcare is taken care of. When you talk about public healthcare, it's very different from. So you need to put if I put 100 crores, I need to maximize my return on the 100 crores. That's how the public healthcare works. So, and if you see the developed nations, their essential list is only 112 or 110 or 120 something. So that is something which we have this concept also called VED, vital, essential, and desirable, of the entire drug list. So there are some drugs you need to have it at every facility. Like when you talk about, there are 30 to 50 essential drugs which should be available in a PSC, and around 70 to 18 in CSC, the secondary care, and around the rest like 100 to 120 in tertiary care. So these are things which, we need to, work on. I think there's a plenty of scope in, public healthcare. When I'm talking about it, I just don't say healthcare, it's public healthcare. Like you said, I would probably use that concept 2080. You invest 100 crores, you can actually take care of, 90% of the population. You might not, so that 10, I would not say that is not the scope of thing. There are other mechanisms to take care of the 10%, but this 90%, you maximize the return on the public money. So that's one thing. I think there's a question from Dr. Srinivas Kamichetti. He's asking what is the most challenging task or application. I would think the last mile delivery is one of those biggest challenges. In fact, when I was talking about the fever surveys, imagine if you are not done the fever survey. I would put it in a different scenario. If you are not done the fever survey, everybody would think that I have a fever, I have COVID, and they'll start, rushing to the nearest facility. And then I would, bottleneck the facility. I would use this word, bottleneck the facility. So that did not happen because we were able to go to house. It's not that they were called to a place. We were able to do house to house survey and find out these are the guys. And in fact, you must have also noticed in this entire COVID time, we were able to give home COVID kits, home care, where there was medicines put in. Even I think food was also given. So, and there was also, in fact, if you see the way we have handled COVID, the first one is home isolation. Second one is, we call it CCC, COVID care centers. And third one was the hospital. So even in the chain of things, we did not push them to the hospital in the first go. We were able to, see whether these people can be taken care of. Because I would not call it squatting, but it did happen in the entire wave too. There were people who could afford, squat or take the, beds where the people could not get it. So that's one thing. So I would not dismiss the size of the wave too, but it's also very important that there was also management issues. So that's also an offtake from the entire wave two, which we learned. So I think the most important thing is the knowledge dissemination to the last mile is very, very important. So it's very critical that we create that soft skilling also, and also the last mile infra, which includes land and even power and infra, and also the physical infra.
Sir, thank you, sir. You also mentioned about PPP, sir, public-private partnership.
Yes.
And what would be the initiatives from the government perspective, sir? How are we initiating? Because I am from Hyderabad, sir, currently operating a project in dialysis along with government of Telangana. So what would be the initiatives from the government in terms of PPP perspective, sir? And in which field of healthcare delivery system, especially this can be.
I'm not going to give you a n number of PPP thing, but I'll just going to give an example. Telemedicine is one area which you can immediately take over. So if you see, when I was talking about the digital healthcare, I'm putting it a scenario. A person from Padero, the nearest best facility is at least 400-500 kilometers from him. Best facility, I'm talking about a best facility. And if you can create an infra where he can go to the nearest Sachivalayam, where there he has an local internet connection, then he uploads or he gets his diagnostic done there. And then if you can access that, somebody in LV Prasad Hospital, I'm just putting an example. So I could, LV Prasad Hospital in Hyderabad, some senior ophthalmologist can see that record and suggest him. And we also have a local healthcare worker who is an A&M or somebody who is trained properly, could deliver that service. I'm just throwing a picture how you can think of. There are n number of ideas like this.
Okay, sir.
It is already available, like the e-Sanjeevani, the pharmacy unit. In fact, the primary care could be like that. So there are n number of ideas which we need a lot of PPP, because this kind of, when I'm talking about telemedicine, is one area where there's a huge PPP which can happen. So there are many areas, like even I could look at diagnostics. So where you can collect data and bring it back and tell these are the most important, because that's one area we also suffer. When I'm talking about health infrastructure, we also talk about diagnostic centers is very, very critical component to it. You must have also seen in the COVID care, CT scan is a very, very necessary component, to understand what is the damage caused by the disease itself. So yes, there is also, again, the bottleneck happened at the CT scans, CT scan centers also. So there is a lot of scope. It's just that how do you want to come in? That's all.
Okay, sir. Thank you, sir.
So, sir, I thought it is appropriate that the students have sent some questions to me prior. And one of the questions I would categorize it as concerning improvement and efficiency in health service delivery. So the students ask, what are the initiatives that are likely to improve the service delivery of government-run health facilities vis-a-vis the private facilities?
No, I think I will take it offensive. How do they think that the private facilities are better than government? So that is one question which we look at, right? So I always think that the service quality, maybe the service experience, I would call it that way, might not be as good as in the government facility, but I think government doctors are even better equipped than the. I would not blame that the government system. I would call it the government system is better equipped than the private system in a lot of ways. So that's what I started my discussion by saying that the way we responded, there's always this thing. I think it's very important that people have to see things in real terms. I was collector of a district called Banda. It's somewhere in Bundelkhand. So this was way back in 2013, 2014. This is one of the most backward districts in the country. And the best facility we had in that, the entire district was the government hospital. Imagine this one, with a population of 15 lakh people, and the best facility you have is a government hospital with 50 doctors. Okay, that's the best facility in the entire district. So there are districts in this country. We have this, urban bias. We always see that most of your students will have this urban bias. They come from, because that's exactly what the IIM students also have it, right? You take your own batchmates, it will be hardly, maybe I don't see, I'm just throwing a number, not even 10% of the people would be from real rural background, if I put it that one. So this is also a very, very important reason you should understand why there is an urban bias in IIM. That's also a very critical question, right? So we should understand. It's also access to the, knowledge, and also access to the, I would not call it, access to things which would make you to achieve the goal. So the similar, when you see it, government system caters to mostly, I think 70 to 80% of the population in this country, which we do not see it. If you see districts like smaller districts, it's only the government system which is, like the way I told you, Banda, with 15 lakh population, there was only one government facility which was facilitating or providing the public care. Yes, the challenge would be to improve. So one of the things which we are doing in the one of my other portfolio is called hospital administration. We are also learning from the private systems to improve our own system. So there are certain standards called NABH, which is the Indian standards for hospitals, and there is also Joint Commission International, which is also the international standard, the US standards for hospital, and there is also NHS. So if you ask me a question, why you guys should learn about NABH or JCI, this is the future of hospital management. In fact, I think you should probably download
accreditation. Sorry to interrupt, but accreditation for hospitals and caregivers.
Yes. Yeah. So these are the codes, okay, which is more like a pilot codes, right? It's like, how do you take care of a patient? What is that facility should have? What is that? There are codes beautifully written. I think this is done because of this great book called, I think this is one book I always suggest, Checklist Manifesto. So this is a great book. I think every management student should read, and it is by a doctor called Dr. Atul Gawande. So he says, out of every 4 cases, one is a medical error. We also have, when you go to an hospital facility, there is a higher chances you get a secondary infection. It's, in fact, the COVID is also, most of the COVID complication is a secondary infection, right? The black fungus which happened, it's also a secondary infection. It's not primary. It's COVID induced secondary infection, right? So this is also very, very important, where you have facility management. So this is one thing which I think probably the hospital management course, or you should also try and do it, is that how do you manage a facility? There are, if I'm asked what are the 5 important facilities which hospital should have, not on the clinical part, the non-clinical part. One would be the diet. Diet should be controlled, because there's a lot of colic which comes in your food. So when your vegetables are, taken in the kitchen, that should be cleaned up. And there is also, process to do it. There is a particular chemical put to clean off all that. There is no colic. there's no infection or food induced infection to the patients which are admitted in the hospital. The second would be, how do you keep your oxygen? That's very, very critical component. And there's also a building maintenance. There are a lot of devices which are attached to that building, where every floor has a different voltage, and these machines are very, very voltage sensitive. So there's also a very deep understanding of the building management system. You need an electrician. How many electricians you need? Do they have to be on the on the prime time, or what is it? Maybe in the downtime they are not there. So this management is also very critical. And the fourth one, I would see it as a sanitary management. That is very critical. I'll tell you a very small example which I really liked. I visited Apollo Hyderabad. So Apollo Hyderabad, what it does is it brings all the laundry from all the 5 hospitals across Hyderabad to one unit, and it washes it. So one of the easiest way of the spread of infection is the linen. It not just spreads, it can go all over across the cities, right? So what they do is, they have when the linen is collected, it is put into water soluble cover. Imagine. So that's all, the matter is closed right there where it is collected. And then it is put into a truck called dirty linen truck. And they carry it to the laundry, get it washed, because this covers go directly into the washing machine. Since it's water soluble, it gets dissolved in the machine itself. And then it is washed, it's cleaned, it's pressed, and then it goes to a new truck called clean linen truck. So these are protocols. These are simple protocols, but the way the infection is controlled. This is a JCI standard, it's Joint Commission International Standard. So we have to get into those kind of nuances to look at how things. In fact, I was doing one internship with one corporate hospital here. It is also important when they take your samples, there are things which are thrown. So when you walk a long distance to throw your dirt, or what you call the rubbish, you also spread the entire distance. Medical waste. So they have created posts, and they kept a smaller bins, so that the medical waste is thrown right there. The people, they don't have to walk it through the entire walkway or take it across. These are smaller differences which I probably we were also talking in the beginning of this conversation. These are also design thinking. There's a concept involved, and there's also, so he told me minimal walk. That's a concept involved. If you have minimal walk, the infection doesn't spread. So these are things which we can look at. So the other is called CSSD, the sterilization of all your equipments which are very, very critical, like Operation OT or things like that. So there are imported devices which do CSD. So as a facility manager, you should know how to handle your facilities, also know a little bit of HR, and financing is also critical because there's a lot of number games which you have to run through. So I think facility manager, if you're director facility management services, it's a very critical job. I think it's also an emerging job. I was also seeing a chart recently. Healthcare professionals would be the most sought over in the next 10 years or something, which also includes healthcare managers. So I think there's a plenty of scope to start with.
So again, if I may, listening to what you just said, can we just say there is enormous need to hospital management? Maybe the doctor is at the center of it, but the perception of the patient and the rating of the service happens really because of the work that the paramedics and allied staff do. In some sense, and you've mentioned that there is a lot of need to improve the soft skills and knowledge and improvement in dealing with at least people and otherwise throughout the healthcare chain, whether be it in hospitals or community health workers, etc., etc. So the paramedics and their improvement in their skill or level of dealing with patients is very much necessary, and we just want to hear your thoughts in those regards, because there's one question that says, what could be the improvements in HR management and the role of analytics is what our students ask.
Yeah, there are two different questions. I think I wanted to answer this analytic question later, because I also wanted to talk on digital and the ABDM initiative. Yeah, so what government is doing right now is it's also creating that paramedical councils across this country. When I talked about soft skilling, the doctor is the center of the healthcare system, but you also need a couple of people around them, like the nurse, the lab technician, and the service people. So it is very critical that we need to, bring them as a unified force to, one of my, when I started speaking this conversation, I think I was stressing on this soft skills all the time. It's not just the doctor, it's also the, ensemble of people around them, which is very, if you see a corporate hospital, you will, when you have admitted in an hospital, you will have 3 nurses taking care of you. It's not just the same nurse comes on every day. 3 different nurses will come and take care of you. And if they do not know, for example, one incident happened with my own aunt. So the injection was given on the right hand. And I think when it was recorded in the case sheet, it was recorded as left hand. Somehow my aunt remembered that it was given in the right hand. And when the nurse came to, put the injection again, she said it was in the right hand, not left. So these are very, very simple mistakes which can happen and which can also turn into a medical error. So skilling is very, very critical component of the entire, system. Analytics part, I think that's one thing I thought I'll conclude this entire conversation with this. When I talked about, collecting a lot of data, we talk about diagnostic data, healthcare records, and we also have inpatient record, outpatient records. We also know the usage of, what medicines were used. This also would mean that we need to, predict for the future. What would be the, I have, you must have also heard of it. Heart attack is not one thing which had just happened. It's a thing which has been happening for the last 2 years. If you know any cardiologist, you would tell you that heart attack is not a thing which happened immediately. You knew it. It's a process which was happening. It was process or it started 2 years back. So if you are having a good diagnostic system which could tell you that this would happen, you can always prevent a heart attack, right? So that's the predictive analysis which we are talking about. So there is a lot of data which is going to come into your system. For example, I don't know, many of you would have realized that during the COVID, they will ask you to, measure your IL-6, ferritin number, how your body is responding. These are the other numbers which were asked to measure post-COVID. Because clotting, you will come to know whether if you are getting a blood clot, if you measure your IL-6 or something like that. So these are very, very small component. In fact, I do not know how many of you know that iteration, if you have a number 32 or 31 or 16, how do you respond to it? So there's a lot of predictions which can happen, which can tell, mobilizing the infra also. When I talk about issues, when we know that this is, so what we do in the normal governmental system, I'll explain that normal governmental system. When we go to PSC center, suddenly we have some 20 dysentery cases there. So the local person there will tell us there are 20 dysentery cases there, and they'll call the district officer, the CMO or chief medical officer, and says there are 20 cases. And a team will go there and they'll start testing the entire village. So similar kind of response can be done. And then you also have seen that one of the reasons, one of the, maybe I would not call it success, or one of the ways we have responded to the wave 3 is that we also have set up our own genome sequencing lab to find out what would be the newer strains which could emerge of COVID. So that is also which has happened. I think the newer genome labs have been established so far. So there's a lot of, when I always talk about data as one thing which can be mined into gold and also diamond. So I think there's a lot of data around. When I also explained that medical insurance thing, we can also predict what kind of diseases would happen. We can also predict, do we need more cardiologists? In fact, if you see the way we have prepared for the wave 3 is that we knew that this would happen for the younger children especially. So these are predictions which have happened because there was modeling done. I think SIR modeling was done, and then so we come to know of it. So there's a lot of data analysis which could come and which should help in public healthcare.
It's very interesting, sir. And as a follow-up question, to me, the simpleton in me sees AB, the Ayushman Bharat Digital Mission, as analogous to the UPI or the United Payments interface that has happened for the financial sector.
I think so. I think we are predicting a lot of things with this one, but I think this is going to change the way. I'll tell you what. This is one of my. It was very funny that I did this project when I was a probationer. I always thought that I always think that when you have a data, we can play with data and find out what is going to happen. So that's very critical. I think data is going to change the way we respond.
Absolutely. And A lot of countries have, and in fact, even India has this NSDAP, National Data Sharing and Access policies for public data. In that context, is there any scope for ABDM data with, of course, set of confidentiality and privacy disclosure and non-disclosures attached? Will it be shared with, let us say, someone in the academia and elsewhere?
I think so. So what has happened in the COVID thing, which I was explaining you, that the APOs were given with the same security, data securities and all, which was thrown. In fact, if you see yesterday, the Aadhaar has asked, how do we, use Aadhaar data to provide better services? So there is this also openness in the government system to, share data. I think that's a very good sign to begin with. And when you were talking about the public health records, can you believe countries like Thailand has already done it? You can't get a medicine without a public health record. There's a digital health record in Thailand, so you need a health record. So we always tell ourselves, or maybe tell ourselves in a wrong way, that we can't do it. When a country like Thailand can do it, we always think that developed nations are the only ones which are doing it. And I'm also told that USA is also going to go big time in digital health records. So being India, we are the leaders in IT always. So whatever we create, we can also provide the same systems to USA or something. So there's also plenty of scope for startups to come in this area of digital services and also products. I think I make a difference between both of them. So there's a lot of startups which could, data analytics based. So we need to lead literature, because this also needs a specialized knowledge. So also have an healthcare management knowledge. It's also required for it. So there's plenty of scope in data analytics area.
That is very, very exciting to hear, at least even for our students who are generally oriented towards doing anything to do with analytics, etc. Sir, if I may ask one more question. It is concerning the outreach of, let us say, public health and health insurance programs, public health programs. So the students ask, how are potential beneficiaries made aware of public insurance, and what kind of initiatives are there in the pipeline to improve that outreach and bringing them into the fold of insurance?
So I would briefly talk about the two systems which I'm closely involved with. One is this Aragyasri of Andhra Pradesh. So if you see it, there is a list of treatments which are available. I think it's around 1600 or something. So these 1600 is available for any citizen of Andhra Pradesh who is covered under, or who or she is covered under Aragyasri. And also, if you have seen, if you now today you can go around and see Vizag when you're traveling around, you'll also see a big board put in front of an hospital, say this is an Aragyasri hospital. And also, you would also notice that we have this Gramavada Sachivalayam. We are also putting the list of hospitals which are covered under Aragyasri. And we also have a QR-based app which will tell you, if you use your Aragyasri QR thing, which will also tell you which are the hospitals which can be, which you can access under Aragyasri scheme. So this is the biggest public scheme. And similarly, one more system which I know very closely is the Tamil Nadu insurance scheme. It also has a similar concept. You can see this one. We just start to see that you would have used it also. So I think in the last maybe 5 years, medical insurance across the country has increased tremendously with the introduction of Ayushman Bharat. So we almost have a universal coverage. If you talk about economic terms, it's more of, money. I would get better use of money, what I would put in the system. That's one thing. So we also will improve. I think it's right now standing around 700 to 750 to 800 crores for 2-3 crores of population, which will also reduce eventually. So when we have better hospitals, better infrastructure.
Sir, Nimi Rajan, our student, also has a question. She asks, different states have different quality of health infrastructure. How can we improve and reach the most needed people? In some sense, how does geographical disparity in health infrastructure itself can be overcome to have the same quality of healthcare for all people?
Yeah, I completely agree with you on this one. I have been in UP. I come from Tamil Nadu, and then I also work in Andhra Pradesh. So I have seen 3 different states where we see a radical change in the health infrastructure. But you also have to see the government's post-COVID. That's one. When I'm talking about public health strengthening, you also realize that governments are, proactively, establishing medical colleges in every district. In fact, we are going to set up 16 more medical colleges in AP. And you also must have seen in UP that newer colleges were established. So that is how we respond. We see the gaps and we try to fill in, but it's going to take some time. So I think that's where we are at right now.
And Dr. Srinivas, who is our executive PGP student, also asks, do we have any possibility to enhance government facility under NABH or any such initiatives in particular
Yeah, we are
areas
trying
of?
to do this because I think of late we have realized that private hospitals have a lot of NABH assessors. There is a term called NABH assessor. So it is very recent. Yesterday's meeting, we have taken a call that every every district will have 2 NABH assessors from the secondary and the primary care, and we also will have 1 NABH assessor, at least, when I'm putting this word, at least 1 NABH assessor from each government hospital, which would mean that organically the hospitals also will better. So the public health system will get better, because if we have their own assessors, they'll also contribute to the development of their own assets. That's one thing which we are looking at very soon.
So
I think we have done a lot of for half an hour.
in the interest of time, but Shoaib, can we take 1 or 2, because we have 5 more minutes to go, and with your permission, sir, can I open
for 55? Yeah.
Okay. Shoaib, what shall we do? Shall we open the floor for 1 or 2 more questions if your friends have any? Or
yeah.
Yes, sir. We can ask the last question for now.
Okay. Anyone amongst the students, if you have any questions to Shri Naveen Kumarji, you can unmute yourself and ask the question. Please keep it brief. If there are no questions, then we'll see.
They're already bored. I think they want to go.
No. In fact, I am tempted to talk a lot, but I'll let the students.
Sir, Naveen Kumar sir, thank you very much, sir, for giving us an elaborative, inputs across the healthcare delivery system and new initiatives. We would look forward, from IIM, in case of any such pilot projects, especially enhancing the government facilities all across AP. So, this is something which I wanted to put you across, sir. Like you just mentioned about NABH standards, bringing up of NABH standards across the government facilities. So we would like to be a part of such pilot programs or projects, sir.
Yes, we'll also contact NABH and find out how do we train our doctors also. Your director can also, someone can get in touch with NABH to create assets. Maybe you must having, I don't know how many doctors are there in your batch. Is there doctors in your batch?
Sir, so
not
far
many, sir.
Not many,
Not
sir.
an MBA.
Sorry, sir.
Not in any MBA batch. No doctors in an MBA batch.
In our regular PGP, which is the full-time MBA program, I suspect if there is any doctor, someone with doctor training. But in our PGP, the executive program, which runs over the weekends, we have Dr. Srinivas ji, who is a doctor. But there are very few and far between.
So there's plenty of scope for your senior, so you should try and get hands on.
Thank you, sir. Even I'm MHA master's degree from Apollo as well, sir. Like as you said, there is a huge scope for all the hospital administration across the fraternities.
So I think, sir, if I may summarize, again, I've been speaking a lot and not letting our students speak, is this, that there is enormous scope for improvement in terms of management knowledge within the hospital and within the health delivery sector. And I think a lot of emphasis or attention should be paid by the students in that regard. If there is one key takeaway, if I may surmise it that way. Would you agree to that characterization, sir?
I agree. I think there's also, we should read, I think last example for the day. How many of you have seen the Zomato page some 5-10 years back?
Can't remember.
So Zomato used to be an information provider. So it will tell you which are the best restaurants available in that locality. Okay. So, and right now you see Zomato, right? So it's also a food delivery service. So the example I want to talk is the repurpose. So we have to repurpose ourselves, our goals, or maybe, when there is a disruption, we also have to repurpose our, goals in a different way to, respond to it. I think there's also a definition of intelligence which talks about it, the way you adapt to these circumstances. So it's very important. I would put it as it's a business jargon, right? So I'm using it for business students. So repurposing is very, very critical. So that's what we should learn or from this entire crisis, the COVID management. We should repurpose our entire response.
Yes, sir. So, coming for the time constraint for this session, so we'll go forward for the last part of our keynote session. So, this is the vote of thanks. I extend a very felt vote of thanks to the esteemed keynote speaker GS Naveen Kumar, sir, who spared his time from his busy schedule to grace this occasion. Today, in today's session, sir, have talked about 6 critical factors of healthcare. Financing for the healthy India, spending 3.5% of GDP, improve infrastructure of strengthen the system, both physical and knowledge infrastructure of healthcare, scaling, then importance of private-public partnership in healthcare and more on. Then we also see about creating awareness of healthcare in Indian population, along with the how police administration and health staff should be response to the health crisis. We have also followed by very interactive and thought-provoking question and answer session. Thank you for sharing these insights, enriching insights for the topic. I would like to thank Professor Kalyan and the faculty of IIM Visakhapatnam for taking out a time from very busy schedule for seamless moderating this phenomenal session. I'd like to thank you again for coming and joining us. Before ending the session, with your permission, I would like to capture this moment so all participation can turn on their cameras.
Okay, if you allow me, Shoaib, let me thank Sri Naveen Kumar ji for his for sparing his time for us. And I suppose I must request you for one more interaction whenever it suits you, sir, with our broader cohort of students.
We'll try to do it physically. If students are available, I'll come.
Yes, that will be really nice. Yeah, we'll be very, very glad to host you and hear from you again at length. And thank you very much for accepting our invitation and coming. Thank you, sir.
Okay.
Thank you so much, sir.
Thank you. Thank you, Joe.
Thank you, sir.
Thank you. Thank you all.
Thank you, sir. Thank you.